Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, we continue our Year of the Zebra series focused on rare disorders by welcoming a leading figure in the field of pediatric neurodegenerative disease, Dr. Mary Kay Koenig of the University of Texas McGovern Medical School. Dr. Koenig holds multiple senior-level roles there, including Director of the Center for the Treatment of Pediatric Neurodegenerative Disease, Director of Research for the Division of Child and Adolescent Neurology, and Director of the Mitochondrial Center of Excellence. Among Dr. Koenig's specific research interests are Leigh Syndrome and tuberous sclerosis and other neurogenetic disorders. Looking forward to her insights on caring for people with these complex conditions and learning about her efforts to develop therapies for them as well. And thank you so much for being with us today.
Thank you. Happy to be here.
So we always like to start with learning more about the background of our guests. You came to a career in medicine after a detour into teaching, as I understand it. Tell us about that.
Sure. I wasn't exactly sure I wanted to go into medicine, to be honest. I started my career as a microbiologist. After completing college, I went and got a graduate degree in microbiology. Both of my parents were actually teachers. My mom taught college and my dad taught high school. So it seemed kind of a natural fit. And I started teaching as a TA in my graduate program. So when I finished my master's program, I started teaching at the local community college and I loved it. But what most people don't really think of as is academic physicians, we're still just teachers. We teach people all the time. We teach our patients, especially in neurology and in neurodegenerative disease. I spend a lot of time teaching my patients about their conditions, about how to take care of themselves. And I spend a lot of time teaching students. I teach medical students. I teach college students. I teach residents. I teach fellows. I'm constantly surrounded by people that I'm teaching. So I get to combine both worlds here in my current job. I work both as a physician taking care of patients, and I still get to follow my passion for teaching.
And why medicine and pediatrics?
Medicine was a passion that I had from a very young age. I really was interested in medicine, and I kind of diverged because I got very interested in science. And so I felt like I wanted to do more what I would call real science, where I was working in a lab. When I started spending all of my time in a lab when I was in graduate school, I realized I wanted to work with people. And so I went back towards the medicine field so that I could work with people. And so I went back into medicine because I just like being around people and I found it to be very rewarding. So I got to do both. I do a lot of research now. So I do a lot of science and a lot of research, and I get to be around people all the time. So it's kind of the best of both worlds. As far as the pediatrics and the neurology, the one thing I did know going into medical school was that I would never work with children. Kids are very difficult. I didn't know much about them, and I knew that I did not want to work with them. But you find out very quickly when you start working in your clinical rotations in medical school that kids are also very resilient. They bounce back from anything, especially kids with chronic conditions. They don't realize that there's anything wrong with them, whereas adults complain about everything. Kids complain about nothing. If they're in the hospital, if they're sick, they don't seem to realize there's anything wrong with them. And so they're wonderful to work with. They'll let you do anything to them, and then they forgive you instantly. And they're just beautiful. They also, from a neurologic perspective, have an amazing ability to recover, much more so than adults do. And that potential for recovery, that potential for improvement, and that potential for their future is just so amazing. And it was just impossible for me to resist. So I did decide to go into pediatrics. The other thing I realized very quickly when I started medical school was that I did not want to go into neurology. My first neurology class in medical school was so difficult, so confusing, and there were all of these pathways that we had to memorize, and they were just boring and they didn't mean anything. And then when I got into my fourth year of medical school, they started making sense because we actually were able to integrate those pathways with people and with syndromes and with medical conditions. And all of a sudden, all of these things that I had to memorize became so interesting and they made sense. And so I really became fascinated by neurology. And in particular, I started understanding how much there was that we still had to learn about neurology, how many things we didn't know, and how much we still had to figure out. That really sparked the research side of me, which was where I'd always started from. And so I really became very interested in neurology and trying to answer some of these still unanswered questions.
And was there a mentor, a key doc, or somebody along the way that also led you to latch on to neurology? We hear that often, that's part of the story often, is that wasn't really sure about this, but boy, I had a great professor or clinician that really took me under their wing.
Not really. There was one that led me towards mitochondrial medicine. So, and interestingly, he didn't do mitochondrial medicine, but when I was in my neurology training, I was trained by a man named Ian Butler, who anybody in child neurology knows Ian Butler. He's been around for a very long time. He still works here as an emeritus professor. And he had an amazing style of education, which was kind of like a parent figure letting you figure things out on your own, but being there to guide you. And he gave people a lot of leeway. And he used to always talk about learning through stories and learning through experience. And so he would very frequently tell stories about his life and his patients and things he'd seen over the years. And I will never forget, it's been a very long time now, but when I was in training, seeing a young lady who was about 20 years old, and we had been consulted from the Pediatric Neurology Service to see her because they felt like she had a genetic neurodegenerative disease. And we went to see her, and he assessed her, we assessed her, and did some testing on her, determined that she had a mitochondrial disease. And I thought, this is fantastic. This young woman's been going around for 5 years. Nobody knew what was wrong with her. We found out what's wrong with her. And I looked at him and I said, this is great. Now we can treat her. And he says, oh no, there's no treatment for this. But at least she knows what she has now. And I said, well, I don't like that. I want to do something. And he said, well, go figure out what you can do. And he gave me the leeway to research on my own. He paid for me to go to a conference on mitochondrial disease and allowed me that opportunity to try and understand what it was that we could do. Ultimately, I realized that in the setting, there was nothing we could do. But from that, that's what sparked my entire career in mitochondrial medicine. And so if you ask me who influenced me the most in my career path, it was Ian Butler.
Just to get everybody on the same page here, remind us of the role of mitochondrial cells and how their dysfunction leads to neurodegenerative diseases in both kids and adults.
Sure. So mitochondria make a lot of people cringe because we always have to go back and talk about things like the TCA cycle and the OXPHOS pathway and biochemistry. And that's kind of for a lot of physicians a sore subject. They don't want to think about biochemistry. It was too hard. It's too complicated. It's too much. But I always say, like I said before, I'm an educator, so I have to teach patients about this. The basic role of mitochondria is to take your substrates, which is your food, and turn it into chemical energy in the form of ATP. So you take your sugars, your proteins, your fats, you run it through glycolysis, beta oxidation, the TCA cycle, and ultimately it goes through the electron transport chain, which is in the mitochondria, and turns it into ATP. Everything needs ATP to function. So if your ATP isn't being produced at the level it's supposed to be produced, you have global system failure. So nothing in the body is going to work the way it's supposed to work. Everybody has to be making some ATP, but it's a matter of how much ATP you're making and what organs you're making it in and what degree of ATP you're making. So if you have a mitochondrial disease where your mitochondria aren't working very well in your heart, you may have heart failure because you're not producing enough ATP in your heart. If it happens to be focused in your brain, you may not be producing enough for your cognition to function, or you may develop epilepsy. If it's your muscles, it may be more of a muscular problem. So the basics are that mitochondria take your food, turn it into chemical energy so that the rest of your body can work. And depending on how severely affected your mitochondria are and what part of your body is affected, it's going to influence what type of mitochondrial disease you have and how sick you are.
So you must just see everything. I mean, the range of presentations must be quite wide.
We see everything. It can onset anytime from birth all the way up until old age. And we do care for patients all the way up until they're, any age, in their 80s sometimes. We've had patients present. And the the severity of the condition can be anything from very mild. Some patients present with just some mild weakness of their eyelids or an inability to move their eyes. Some people just complain of fatigue, or they have some mild muscle weakness, to very severe, devastating presentations that result in early death, even in infants.
And it can be happening in multiple systems at the same time?
Yes. So there are literally hundreds of different types of mitochondrial diseases. And depending on what type you have, it depends on where and how severe it is. So we currently know of about 1,500 different genes that are required for mitochondria to function appropriately. And so, again, depending on what type of gene is dysfunctioning, is really going to influence what type of mitochondrial disease you have. And in a lot of situations, it's different, even in people that have the same gene defect. So it can be influenced by so many different factors. It can be influenced by your environment. It can be influenced by how old you are. It can be influenced by exposures. You're exposed to a certain metabolic stressor, and that can alter your function of your mitochondria.
So I'm remembering what you said in that early anecdote about, there wasn't much that could be done for that patient you encountered, but that story has changed somewhat, partly because of the work that you've been doing down there at Texas McGovern Medical School. So tell us about the UT Mitochondrial Center of Excellence and how it's evolved in almost 20 years now since you founded it.
Yeah, so we opened our doors in 2007, and I say we, I mean me. I decided back in 2007 that I wanted to start a mitochondrial clinic, and I remember at the time being told I was crazy. There were not enough patients with mitochondrial disease in the world, and I would never be able to have a successful clinic. And here we are 20 years later. So we now have 2 dedicated neurologists. We have an entire team of subspecialists, including endocrinology, cardiology, gastroenterology. We have a palliative care physician, an endocrinologist. We have a social worker. We have therapists. We've got a whole team of people taking care of our mitochondrial patients. We have a comprehensive research team. Currently, we have 2 interventional studies that we're working on. We have 2 observational studies, and then we have several expanded access research programs where we're bringing experimental therapies to patients who otherwise would not have access to them. So we have an entire center here where we're taking care of people with mitochondrial disease, and we're providing them with therapies either that are being investigated or that we believe are potentially going to provide them with benefit. And we're also doing a lot of international collaborations, looking at the natural history of these conditions so that we can understand more about them to try and help carve the future for therapies as they're being developed.
What are some research highlights that you'd like our audience to know about?
So since I started doing this, we know so much more about these conditions. So one of the huge successes that we've had is that we are able to recognize these diseases much more. As I said, when I started, I remember someone telling me, we only diagnose one of these every 5 years. Well, I diagnose one of these about every 5 days now. They're here. They were just not being recognized and diagnosed. So now they're being diagnosed a lot more frequently. And with that increased diagnosis comes increased understanding. So that has been a huge win, not just here in Houston, but all over the world. And that in and of itself has led to improved survival and improved quality of life in our patients. If we know what you have, we know a little bit more about how to manage you, and we understand your disease a lot better. We still don't have any FDA-approved therapies for mitochondrial disease, but we do have some therapies that are showing really promising results. And as a community, we're hoping to see some approvals really soon. We have 2 drugs that are currently under review by the FDA, and there's a lot of hope that those are going to be proven to be successful and are going to get approval. There's been a lot of increased collaboration and organization among the mitochondrial disease community and the physicians. So again, a lot more information, natural history collaborations, and understanding of what outcome measures we need to be looking at so that we can be performing successful clinical trials. And the other thing that is really exciting for me is this improved education of the young generation. So we now have mitochondrial disease in the medical schools. We're teaching the students and the residents about this. You don't get out of McGovern Medical School without knowing what a mitochondrial disease is and having seen some patients with it. When I was in medical school, no one had ever even heard of it. I think people were still saying you can't get a disease by having a problem with your mitochondria. Sure, you can. And now that's just a statement of fact. Everyone knows that. And so those things are really exciting, and they've really changed the way people are thinking about mitochondrial disease.
That's an amazing arc in the course of one career, to travel that far. So in terms of the therapies you mentioned, is there a commonality in terms of the method of action? And what other, people hear a lot about gene editing and other, technological advancements. Talk about how that plays into what you're doing.
Yeah, so there's a lot of different kind of directions that people are looking at right now. So it's always hard to know what's going to work and what's not going to work. Things work great in petri dishes that don't work well in people. And so one of the methods that people have looked at is trying to do a modification kind of the redox state. So one of the problems we know in people with mitochondrial disease is that they have a lot of free radical production. They have a lot of oxidative stress within their cells. And so people have tried various targets to try and just globally reduce that oxidative stress. I kind of equate this to someone who has a cough. You can have a cough for a whole bunch of different reasons. It can be because you have lung cancer, or because you have pneumonia, or because you have asthma. Any of those things can cause a cough. But if you give someone a cough suppressant, they're going to stop coughing. It doesn't really matter why they're coughing. And so a lot of the mitochondrial therapies that have been developed so far have looked at some of these global problems with mitochondrial diseases. So we know what some of these global problems are. You have this problem with the redox state. So there's increased reactive oxygen species. And so we want to get rid of those. And then there's also a lack of ATP production. So we want to boost ATP production. And the theory behind these is they should work for all types of mitochondrial disease. Boost ATP, reduce oxidative stress. And there have been some studies that have been done. They haven't been overly positive. They haven't had a lot of successful results. It's hard to say whether it's because the therapies aren't working, or it's because these trials are new, because we've had a lot of variation in the patient population. We also don't really know what the natural history is of these disorders. So how do you know if something's working if you don't really know what the patients are supposed to be doing? And so I think there's a lot of reasons why we haven't had success in those clinical trials, but we're hopeful that the more information we gather, the more homogeneous the clinical trial populations become, and the better we become at conducting these trials in these populations, that the better these results and these trials are going to get. The other types of therapies that have been looked at are more disease specific. So if we know where the gene is and what the problem is, maybe we can target that. And so there have been a couple of therapies that have looked at that problem. So for example, there's a therapy that was developed looking at thymidine kinase 2 deficiency, where we know the problem is a particular nucleoside is not being formed properly. So some researchers developed a nucleoside replacement therapy. They developed the nucleoside replacement. They provided it to the patients. They have done some clinical trials that have shown amazing efficacy. And that's more of a targeted approach. It only works for one type of mitochondrial disease, TK2D deficiency. So that type of therapeutic approach has been successful, a little bit more successful. And there's a couple of other therapies that are being developed at this time that are a little bit more targeted like that seem to have some more potential for targeted success. It's not treating the whole disease, but it's a little more targeted. I think there's a role for both types of therapies, and I think both types are still being investigated. We still just need to narrow down a little bit more of our clinical trial development and our ability to perform these trials, which is kind of new in this field.
And it's a very complicated, long road to do clinical trials, as I think most people listening can appreciate. So I mentioned earlier that you also focus on tuberous sclerosis. What would you like our audience to know about your work in that area?
So tuberous sclerosis, I always say, is like the opposite end of the spectrum of mitochondrial disease. So tuberous sclerosis is a disease that has been well known for a very long time. And there were a lot of natural history studies that were done when I started in this field. There was a lot known about the condition, and people felt like they had a very good understanding of its natural history. We know a lot more now, but at the time, there was a lot known. The other thing that was very interesting about tuberous sclerosis when I started in it was that a therapy was emerging, a very effective therapy was emerging. The first publications on it were in 2006, and I joined the tuberous sclerosis field in 2007. And we have had 4 FDA approvals for targeted therapy for tuberous sclerosis that came very quickly over the following 10 years right after I joined. And so it's been really fun working in that field because the treatment advanced very rapidly for this very rare disease. And yet it's also the opposite of mitochondrial disease in the sense that it is rather homogeneous. Instead of there being 1,500 different genes that cause mitochondrial disease, there are 2 genes that cause tuberous sclerosis, and all the patients have a very similar clinical phenotype. The severity for them varies, but the phenotype itself is very similar. And so it's been really fun working in the world of tuberous sclerosis, watching these treatments become available for these patients who previously had no therapy, watching things like the brain tumors, the astrocytomas that previously had to be surgically removed multiple times throughout a patient's life, now being fully responsive to a medicine that has limited side effects, and we're able to just administer a medication to them. And that medicine also helps their kidney tumors, and it also helps their seizures. And so it's been really fun watching that develop and helping those patients kind of grow into this new therapeutic age with their condition. There's still a lot of research being done in that field. There's still a long way to go, but the difference kind of in the level of optimism that people have seen because they had these successes. It's been really fun to work in that field.
Yeah, no, I bet. And as you say, kind of the opposite track of what's been happening with mitochondrial disease. So, as you may know, Osmosis is a teaching company, and one of the things we like to do is fill knowledge gaps. So one of our favorite questions for guests is, what is a gap in knowledge, a myth, something that really bothers you that isn't taught in medical school, that sort of thing, or that the public doesn't know about, that you would say to us, you guys really should make a video about that? What would that be?
Well, I think that people still have a lot of misunderstanding about genetic testing. So I think a really comprehensive video about what is genetic testing and what are the different types. When should you get it? What kind should you get? Working in genetic neurodegenerative diseases, we still see a lot of people who either don't order genetic testing, order the wrong kind of genetic testing, or have no idea how to interpret it once they get results back. And I think there's a lot of mystique still around it. Even in the young guys that are still coming out of medical school, they still don't seem to have a lot of understanding about what is a variant of unknown significance and what do I do when I get that back? Which is the best test to order? When should I order it? So I would love to see that.
Yeah, well, and it's because it's getting so popular, it's sort of like an ordinary thing in the life of a clinician to be ordering these tests and trying to interpret them. So that's a very good point.
And I think physicians need to be better at educating their patients on what they're ordering and why they're ordering it and what it means to the patient when they get those results back.
Right. So as we wrap up here, I wanted to ask you 2 questions in terms of advice you would be providing to learners and early career professionals. One is about dealing with the rare disease patient community. What are some thoughts about special considerations, they should have about that?
So in dealing with the community, I think one of the most important things is remembering it's okay not to know everything. So I think a lot of physicians, especially early in their careers, feel like they're supposed to be the ones that are teaching the patient stuff. But when you have patients with rare diseases, remember these patients, these families, they live with this every day. Most of the time, they're going to know more about their disease than you do, if this isn't your specialty. Don't try to pretend like you know more than them. Be honest with them. I don't know that much about this. Can you help me, or can you tell me where I can go to learn more? a lot of patients will appreciate that honesty, because what they don't want is a physician trying to tell them something wrong. And a lot of our patients experience that, where they're trying to tell their physician something like, my rare disease specialist told me I need XYZ, and the physician says, you don't need that, because they don't want to listen to the patient. So if you're dealing with a patient with a rare disease, please listen to them and admit when you don't know something.
No, and that's a common theme we hear is listen to the patient. And if you start there, then things are bound to go a little more smoothly. And then the other category of advice is just general career advice. I mean, it's always a complicated time to step into medicine, it seems to me, but maybe AI is making that even more complicated. There's always things swirling. So, you're dealing with med students all the time. So what's your go-to advice to them?
So don't get stuck on anything. Just like me, I was sure I wasn't going into pediatrics, and I was sure I wasn't going into neurology. Never be sure of anything. Keep your mind open to everything, especially when you're starting medical school. But even throughout your career, there's lots of physicians that I know who have changed careers because they got into something and they decided it just wasn't what they thought it was going to be. This is a great field, and it's a field of medicine. There's so many different things you can do. I think that's my biggest advice is you have to be enjoying what you're doing. When you finish medical school, you don't get a job as a doctor. You become a doctor. And you are a doctor 24 hours a day, 7 days a week. Because if you're at the park and someone starts choking in front of you, you are going to be the one to step up and help that person. So it's who you are, and you need to be enjoying it and enjoying your life. And so find something you love and do that.
That's great advice. Well, listen, Dr. Koenig, this has really been a pleasure to spend time with you and to learn about everything you're doing down there. And I want to thank you for your time and wish you all the best. You're welcome. It was nice talking with you too. Have a great day. I'm Michael Carrese. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.